Rob, thank you so much for your really lovely introduction. Thank you for having me here today. I am really thrilled to be here in a room full of people who care so much about BDD. Thank you to all of you for being here. You are part of the effort to get BDD out there, better understood, better recognized. Thank you so much to the Foundation for taking this important step, for creating a foundation devoted to BDD. Thank you to the conference organizers, to David Veal, to Rob Wilson, to the Foundation, and everyone who was involved in making this day possible. So I think, you all know, you know that BDD causes so much suffering. And that's really why I decided to focus my work, my life, on this disorder. I was seeing patients, actually back in the late 80s, when I was still training to become a psychiatrist, who thought there was something, terribly wrong with how they looked, and yet to everyone else they looked just, there was no problem. There was no problem. There was just a complete mismatch in terms of how they saw themselves and how others, versus how others saw them. And the suffering was really incredible. And at that time, our field, the public, professionals, the field really didn't know about BDD. What were the symptoms? How did it affect people's lives? How do people get better? We had no treatments. We have come so far. And so many people are now part of the effort. David Veal, Rob Wilson, their colleagues, others have all been part of that effort. And we now know so much about BDD. We have a long ways to go, that is for sure. But we are leaps and bounds ahead of where we were 25 years ago. And I think it's partly that scientists, medical researchers, psychologists, researchers have been part of that effort to really understand this disorder and publish scientific papers about it and publish books and do interviews in the media. And also the public has been a tremendous resource in terms of getting the word out. And now this foundation is a very important part of that effort. And the good news is now that most people really can get better. We have treatments that really do work. And thank you, Carla, for your amazing, amazing presentation and for your story. And it's just so wonderful that you're willing to share your struggles and your ultimate recovery from this disorder. So thank you very much for that. So I'm going to give an overview of BDD and kind of summarize the basic symptoms of the disorder, how it affects people's lives. I have a brief video of two people with BDD who talk about their experience. And I'll talk a fair amount about treatment and treatments that we now know work and really help most people who have this disorder. So at least in the US, we need to show these slides so you can see. So first, what is BDD? Well, BDD is a disorder in which people see themselves differently than others see them. They see themselves as ugly, unattractive, abnormal, deformed, etc., something very negative, but others simply don't. There's a huge mismatch in terms of how people with BDD see themselves versus how others see them. And they obsess about their perceived ugliness, which causes a lot of emotional distress, a lot of suffering, and interferes with their day-to-day life, usually both. And then another key feature is that people with BDD perform repetitive behaviors in response to their appearance concerns. For example, mirror checking, comparing with others, compulsive grooming, and skin picking. And these are just some of the core features of BDD, which everyone shares. But of course, each person's experience is unique in some ways, and their own in some ways. But these are kind of the key features of BDD. Now, what is BDD not? It is not vanity, as Carla said. It is not anyone's fault. It's not the sufferer's fault. It's not a carer's fault. It's not the parents'. It's nobody's fault. It's a disorder that people get. It's not just normal adolescent appearance concerns. That's a misunderstanding about BDD. Oh, she's just going, she's just a normal adolescent. Well, yes, adolescents can have some appearance concerns, but they can also have BDD. And BDD is not trivial. I think finally, scientists and professionals are recognizing that these are not true of BDD, and I hope all of you recognize that these are not part of BDD. I think the public more generally is starting to understand that as well. So you may be familiar with DSM-5. This is the official diagnostic system in psychiatry that categorizes different mental disorders. And here's the official definition. DSM-5 is the new version of DSM. It was published a couple years ago. So each version, updates and refines the definition a bit as we learn more about it. So it consists of preoccupation with one or more perceived defects or flaws in physical appearance that are not observable at all or appear only very slight to others. So when you meet someone with BDD, you really can't tell by looking at them what they're going to be worried about. At some point during the course of the disorder, the individual has performed repetitive behaviors such as mirror checking, excessive grooming, skin picking, reassurance seeking, or sometimes these repetitive behaviors are more mental acts comparing with others in response to the appearance concern. So this is a new part of the definition that was added to DSM-5 when it was published a couple years ago. It is a core feature of the disorder. And then the preoccupation must cause clinically significant distress or impairment in functioning. That helps differentiate it from more normal appearance concerns, which the vast majority of people have. Occasional thoughts, I don't like how I look today, I don't look quite right. But really, what's different about BDD is the distress, impairment, and also the preoccupation. And then finally, criterion D basically says that if a person is worried only that they're too fat or weigh too much and they actually have an eating disorder, then you would diagnose those concerns as the eating disorder, not as BDD. But some people have both. They have an eating disorder, but they also might be concerned about other parts of their body and think that they look abnormal in some way when they absolutely do not. So these are called specifiers. These are new to DSM-5, a new part of the definition. So once the diagnosis is made, so this is how you make the diagnosis. I mean, it's fairly straightforward, actually. Once you make the diagnosis, you further characterize the clinical, the person's symptoms, their presentation, as to whether they have the muscle dysmorphia form of BDD. This form of BDD occurs primarily in men who are preoccupied with the idea that their body build is too small or insufficiently muscular. And so basically they would get a diagnosis of BDD, muscle dysmorphia specifier. So it's a little bit different from other forms of BDD, but essentially a type of BDD. And these are usually men who think their body build is very tiny and that they're not muscular enough. And in reality, they look entirely normal, and sometimes they're hugely muscular because they work out so much, for example. And then a new specifier for the new definition in DSM-5 is degree of insight regarding the BDD beliefs. For example, I look deformed, I look ugly, whatever the belief might be. And we specify levels of insight. So with good or fair insight means that the person recognizes that their view of themselves is distorted and that this belief that they look abnormal in some way is really not true. With poor insight means that they think their beliefs probably are true. And with absent insight, we also use the word delusional beliefs. The person's completely convinced that their view is correct and everyone else is wrong. And before treatment, we find that poor insight and absent insight are the norm. About 70% of people have poor absent insight. And I think sometimes this is an impediment to getting treatment, or the reason psychological treatment, and the reason many people with BDD want cosmetic surgery or other cosmetic procedures, which appear to not work for BDD. But once people get treatment, their insight often gets better. And they start to see themselves more the way other people see them, and to recognize that these flaws and defects that they perceived aren't actually there. Now, BDD was recognized back in the 1800s, so this is one of my heroes. He was an Italian psychiatrist, Enrico Morselli. He recognized BDD. He coined the name dysmorphophobia, now called BDD, and he recognized the suffering that this disorder causes. And he described it. He described patients he was seeing. And it was described over the next century, but really it wasn't until the early 1990s that researchers started really systematically trying to understand this disorder and characterize the disorder and come up with treatments for the disorder. But it was recognized long ago. And in recent years, there have been quite a few prevalence studies that have been done, so addressing the question of how common is BDD. There have been 4 nationwide epidemiologic studies, so surveying a representative subsample of an entire country, entire population. So 1 in the US, 2 in Germany, 1 in Sweden. And you can see that they're very consistent in showing that BDD affects about 2% of the population currently, about 1 in 50 people. So it's more common than anorexia. It's about as common as OCD. It's not rare. Often goes unrecognized, though. I think in part because people with this disorder are often reluctant to talk about it. Often there's a sense of shame and secrecy, but it is out there. So when Carla says you're not alone, you're really not. There are a lot of people with this disorder. And you can see the prevalence in other specific groups of people. Quite a few people seeking dermatologic treatment, and cosmetic surgery. A very good study was recently published, probably the best one yet. It was published a few months ago in one of the leading plastic surgery journals, showing that about 13%, that's the best estimate we have so far, about 13% of people with BDD, or who seek cosmetic surgery, actually have BDD. I'm now going to tell you a bit about the clinical features of this disorder, and this is from more than 500 individuals who were evaluated in my program. And there's smaller studies from around the world that come up with very similar findings. So we find that the average people who come to see us are in their early 30s, but I've seen individuals as young as 6 with classic BDD, as old as 80. It can affect people of any age, and I think probably as many of you know, it usually starts in early adolescence. 2/3 of people with BDD have onset of BDD before age 18. 12, 13 is the most common age for it to begin. And I think, about 40% are male. I think another misconception sometimes is that BDD is like eating disorders and affects mostly women, but it's really, affects both genders. And a lot of people with BDD are single. I think many, tend to avoid relationships and feeling that they're not attractive enough to be dating or in a relationship. And as I mentioned earlier when I discussed the DSM-5 definition, so the people with BDD have obsessional, very distressing preoccupations about these perceived defects in appearance. They seem to see them, whereas others don't. And it can involve any body area. And the thoughts are very difficult to resist or control, a lot like obsessive-compulsive disorder obsessions. They come unbidden into the mind. They're intrusive. They're really difficult, unpleasant thoughts like, I look ugly, I look terrible, people are laughing at me. And difficult to resist or control, so if you say just stop worrying about it, well, you can't. I mean, it's difficult. I will say it's very difficult to simply will yourself to stop thinking them. It's one of the things that makes this a disorder and not just normal thoughts about disliked aspects of appearance. And the thoughts are quite time-consuming. On average, we've found between 3 and 8 hours a day is spent obsessing about the perceived flaws. Usually at least an hour a day. That's a cut point we make for the diagnosis. Most people with BDD obsess for at least an hour a day, and some people say it's all they think about all day long. As I mentioned, insight is usually absent or poor. About 35% of people are completely convinced that their beliefs about their appearance are accurate. And then what we refer to as BDD-related ideas or delusions of reference or comment. So that's sort of psychiatric lingo for thinking other people are taking special notice of you in a negative way. when they're actually not, but they're perceived to be by the sufferer. So if someone looks in your direction, you know, you think, oh, they must be thinking, you know, they're laughing at me, or if they walk by people talking, oh, they must be talking about how ugly I look. It's kind of that immediate assumption, when in fact that's not the case. So that's another form of, another type of misperception. Now I think BDD has a lot in common with obsessive-compulsive disorder, but they are different in some important ways. And they both are characterized by the obsessive thoughts and the compulsive behaviors that are done in response to the obsessive thoughts, to try to check them or hide, you know, check or hide the body areas. But I think one important way in which the two disorders do differ is in terms of insight. So this is a study we did in which you see the blue shows people with OCD, 299 people with OCD. The red is people with BDD, 327. And we interviewed them all with a scale called the Brown Assessment of Belief Scale, and you can see here level of insight. And you can see the pattern is almost completely opposite. So people with OCD generally recognize that their fears, their underlying beliefs are not true. So, for example, if they feel they have to check the stove 30 times so the house doesn't burn down, if you really ask them, do you really think that if you don't check the stove 30 times, the house will burn down? Most of them will say, no, I worry about it, but I think it probably won't. That's pretty good insight. Whereas with BDD, it's almost the opposite. No, I think I'm right. I think my view of how I look is correct. And I think this is one of the challenging things for carers, for those for friends, for those who care so much about the person with BDD. You can't just sort of talk them out of their views of how they see themselves. And it's one of the challenges, I think, in working with people with BDD. And I think also here you can see that most people with OCD recognize that their belief, like that if they hit a bump in the road, they ran somebody over and that, you know, some harm occurred. Most of them realize, well, no, that it's really not true. It's really just that they have OCD, which is making them have this irrational thought. But with BDD, quite a few people, some recognize that they have BDD, but many do not recognize that they have BDD, even though they do. But often, as I mentioned earlier, insight improves with treatment, and they start to recognize, oh, I have a disorder called BDD, and my view of myself is distorted. Here are the main areas of concern. BDD can affect any part of the body. Skin is number one, it's most common. About 3/4 of people with BDD obsess about something with their skin, you know, often thinking they have horrible acne or horrible scarring or marks, or skin's too red, too white, when in fact it's not. Hair concerns, often concerned that they're going bald or they have too much facial or body hair, hair's uneven, something's wrong with it. Nose is number 3. Often people worry it's misshapen or it's the wrong size. It can be any part of the body, and there are even more areas than this that people can be worried about, thinking there's something wrong with the appearance. And on average, we have found that over the course of the disorder, people are concerned about, on average, 5, 6, 7 different body parts. But in some cases, it's just one. And in some cases, people say, I hate everything about how I look. So it can be pretty much anything. I mentioned earlier the compulsive, repetitive behaviors that people do in response to their negative thoughts about how they look. And these behaviors are very understandable, because if you think you look terrible, you try to check it or hide it or do something about it. The problem is that they typically don't make the person with BDD feel better, and they typically take a lot of time. But they're very strong urges to do these behaviors, and if you simply say to the person with BDD, just stop, just stay out of the mirror, you know, just put the comb down, it's very difficult. Much like the compulsive, ritualistic behaviors of obsessive-compulsive disorder, OCD. So one of the things we do in treatment, of course, is try to help people gain better control over these behaviors and gain better control over their own thoughts, so that they don't get hijacked by these negative BDD thoughts about how they look. So the most common behaviors, camouflaging, trying to hide what they don't like with their hair, with clothes. It is a safety behavior, you know, trying to prevent a feared outcome, such as having people look and see the person, but it also can have a very repetitive, ritualistic, compulsive quality to it, where it gets done repeatedly, like reapplying makeup over and over during the day. Comparing with others. This is something people with BDD often do, about 90% at some point during the course of the disorder. And people, what we have learned is that not only do people with BDD vastly underestimate their own attractiveness, but they tend to overestimate the attractiveness of others. And that creates a real problem, because there's this huge gulf then between how you think you look compared to others. And mirror checking, very common, very typical, and as I think many of you know, it's often at close range and sometimes with magnifying mirrors and lights, and I think that this process of mirror checking actually can change how you actually see yourself. I work with some vision scientists, and we have a theory, we don't know if it's correct, but that if a person spends hours and hours a day in front of the mirror, especially at close range or with magnifying mirrors, probably changes your brain and how you see yourself. And further, gives you an even more distorted view of your appearance. It widens the gulf between how you see yourself and how others see you. Compulsive grooming. About more than 50% of people with BDD compulsively, sometimes it's shaving their face, hairstyling, hair combing, reassurance seeking, do I look okay, can you see this on my face? And typically, because the insight is so poor of people with BDD, they tend not to believe the reassurance that they obtain. And of course, those who provide reassurance are telling the truth. Yes, you look fine, you look beautiful, it can take a variety of forms, but the person with BDD has this terrible, very poor insight and a distorted view of how they look. And so I'm sure many of you have experienced how difficult the reassurance seeking can be, and everyone ends up feeling sort of misunderstood in the end. But I think you just have to understand that there's different perceptions. Different people have different perceptions. Compulsive skin picking. More than a third of people with BDD compulsively pick their skin, trying to make it look better, and it's very compulsive driven behavior. And sometimes, especially if you use sharp things to pick, you can actually, some people can actually damage their skin in some cases as a result of the skin picking. Although I usually find after people get treatment and stop the picking, it's amazing how the skin repairs itself. It's quite remarkable. Compulsive tanning, we find that about a quarter of people with BD tan, which I'm sure you all know is a dangerous behavior, risk of skin cancer, but tan in response to BDD concerns such as, oh, my skin is too pale. And these are just the most common behaviors. People do all kinds of things to try to alleviate their distress, but typically these behaviors are not helpful in alleviating distress. And so in treatment, we try to help people gain better control over these behaviors. Now, a really important question over the years is how does this disorder affect people's lives? And I think the answer is a lot. And some people manage to function reasonably well, but it often is really hard for them to do that. It takes tremendous effort. And sometimes it takes a lot of extra time to make up for time that's wasted, sort of wasted with BDD thoughts and behaviors. And some people at the more severe end of the spectrum are completely debilitated by this disorder. So we have different samples of people with BDD where we assessed the impact of BDD. And we found that in the past month in one of our studies, that 39% of people with BDD were currently not working because of some mental illness, and usually it was BDD. That was usually the most primary diagnosis. A lot of people had dropped out of school because of BDD, feeling too ugly to be seen, not being able to focus and concentrate because of the obsessive thoughts, having to leave to go to the bathroom and keep checking in the mirror, leave class. Many have been housebound, not able to leave the house because of BDD. Many have been hospitalized psychiatrically. And then I think what's most concerning is that it's quite common for people with BDD to think life's not worth living, or to even wish they were dead, or to attempt suicide, often because of the BDD thoughts themselves. And to me, this is the most difficult thing about BDD. It is the most heart-wrenching thing about BDD. I think we have to talk about it, though, because I think it illustrates how how much suffering BDD can cause. But again, I come back to the treatments that we have. We do have good treatments that help the majority of people and that can decrease suicidal thinking. Quality of life, we've used a variety of good questionnaires that measure quality of life. This is one called the SF-36. It's a self-report, paper and pencil kind of questionnaire. And what's nice about it is that there are what we call normative scores. How do people usually score who are from the community, who have depression? And then these are BDD scores of people with BDD. And low scores are worse. So you can see that in terms of overall mental health, limitations in your day-to-day functioning in your role, such as a parent or such as a teacher, your ability to function in your role is diminished if you have BDD, and your social functioning is diminished too compared to those from the community without BDD. And again, in our treatment studies, medication treatment studies and therapy treatment studies, we find that when people with BDD get better with these treatments, their quality of life and their ability to function really dramatically improves, and in many cases just becomes normal again, which is really, really gratifying. So I'm going to show you a brief videotape of two people with BDD.
Well, Patricia O'Neill can't stop looking in the mirror. She too is obsessed with imperfections in her skin, but has to constantly check her appearance.
Mostly when I'm driving, which is the worst place to look at yourself in a mirror, in the daylight in a rearview mirror.
Is it true that at one point you took your father's razor blade to your face?
Yeah, that's true.
What were you thinking?
I was thinking I couldn't stand the way my skin looked. I mean, I didn't do the razor blade in, I just kind of, pulled it over my skin thinking I would, smooth out the texture of it. I really don't know what I was thinking.
Like most people who suffer from body dysmorphic disorder, Patricia, who's 32 and single, felt too ashamed to talk about how out of control she felt. The basement studio where she works alone as a sign painter became her hideaway, and the only place where she could let out her desperate feelings.
I could cry there and no one could see me. I would be there and cry. Because I couldn't think of how to explain it to anybody. I couldn't think of where to start.
How would you describe the pain that you went through?
Desperate. Totally desperate. Like I'd rather be dead. Like it would be easier for me to be dead. Easier for my parents and my family. I was ashamed.
Kathy thinks her appearance is so frightening that she agreed to be interviewed only if we promised not to use her last name and keep her in shadow. She's had body dysmorphic disorder for 20 years, and for one 6-year period, hardly left her house.
I was totally debilitated. I thought of nothing but suicide and knew that I couldn't live looking the way I looked. I stayed upstairs in my house and I walked from my room to my mother's bedroom over and over until I put in like at least 5 to 10 miles a day. And that was my whole day, just walking back and forth.
On the few occasions when you did go out of the house, how did you feel?
I felt like a monster, that everybody was looking at me. The cars would get into crashes when they saw me, because they'd be too busy looking at how ugly I was.
And when you looked in the mirror?
My heart would sink, and I couldn't live. I'd be heartbroken.
This is Kathy's self-portrait. This is literally what she sometimes sees when she looks in the mirror.
My cheeks are really flat, like just really flattened out. My face is all different colors and all different blotches, and I just feel like I'm ugly, period.
How does Kathy look in reality? Well, this photograph at age 12 shows just how pretty she really is. It's the only photograph she has. All the others she destroyed.
I'm really happy to tell you both of these patients got a whole lot better, and that's the norm if you get the right treatment. Patricia, the sign painter, medication, that's all she had. She within a few months, started living a normal life. Came out of her basement, started dating, did incredibly well. Kathy had quite severe BDD, as you could see. Her road to recovery was more challenging. She was incredibly persistent. She got medication, she got cognitive behavioral therapy, and she eventually recovered. She started working as a receptionist, she started dating, and the BDD thoughts just receded. She really, really got better. So I offer this as hope, no matter how much you have suffered or a family member has suffered with BDD. The vast majority of people will improve with the right treatment. I'm going to talk more about treatment shortly. So I'm often asked, what causes BDD? And I think the short answer is we don't really know. And scientists are trying to figure this out. It probably is due to a combination of many factors. It's not just one thing that causes BDD. So I think probably genetic factors, probably many, many different genes are involved. We don't really know exactly what those genes are. Visual differences in how people process visual images. I'm going to say a little bit more about that, with an over-focus on tiny, tiny details when they see something. Bias for threatening interpretations. This is kind of part of the disorder that, if someone looks at you, people with BDD tend to assume that the person is looking at them with a negative look on their face, kind of a contemptuous look or a threatening look, when in fact that's not the case. And we see that in other disorders as well, like anxiety disorders. Like OCD, there seems to be a part of the brain that's overactive in BDD. It's an obsession circuit in the brain that's overactive and probably driving these obsessional thoughts. Maybe evolutionary factors. Probably all of these disorders have some evolutionary basis, with symmetry being important in the animal world, for example, signifying health and reproductive fitness, for example. Environmental factors, perhaps a history of teasing. Many people with BDD report that they were teased a lot as they were growing up. What we're not sure, though, is were they really, or were they more sensitive to it? And they remember it more, and it's more wounding, that emotionally, and we don't know. And then, people with BDD tend to be more introverted, they tend to be more rejection sensitive, perfectionistic. But we don't know if these traits, and certainly don't characterize everyone with BDD. These are just tendencies. And what we don't know is do these traits, these personality traits, predispose to BDD? Are you more likely to get BDD if you are this way? Or is this more a result of BDD? And that we don't actually know. So I think those of us who do research in this area are really trying to figure this out. If we can figure out what causes BDD, I think we can get even better treatments. We can develop even better treatments and maybe prevent the disorder. So hopefully that will come in the future. MRI scanner that kind of shows brain activity while you're in the scanner, and people look at faces while they're in the scanner. And people with BDD tend to over-focus on tiny details when they look at a face. And you can even see excessive brain activation in the part of the brain that's specialized for visually processing little tiny itty-bitty detailed things. Little things on the face or little edges of things. And people with BDD also have what we call reduced visual processing of the big picture, holistic information. So when you look at a face, you kind of just know that it's a face, even without staring at the little details. It's the big picture. It's a face. And our brains have this sort of holistic, they see the face in a holistic, big picture way. People with BDD have reduced, their brain isn't as active when they're trying to see the big picture of a face. And it kind of fits with the symptoms of BDD, this over-focus on tiny, tiny little things and difficulty seeing the big picture of how the person looks. And in addition, when looking at their own face, parts of the brain that are overactive in OCD also appear to be overactive in BDD. So that was this obsessing circuit. I don't know if you can see these little yellow things lit up, the orbital frontal part of the brain, the caudate. These are parts of the brain that are overactive in people with BDD when they look at faces in an MRI scanner. Same pattern we see in OCD. It probably reflects the obsessional preoccupation. Then we've recently been learning that this bias, this tendency to overanalyze details of a face and difficulty seeing the big picture of a face extends beyond faces to houses, to the complex figures. If you see this complex figure up here, people with BDD, when asked to redraw it from memory, tend not to draw the big elements in the picture like these. They tend to focus on itty-bitty, teeny tiny details. Like people with anorexia, like people with OCD, so this over-focus on detail, difficulty seeing the big picture. And then there's a task called inverted faces, where if you see these little faces, most of us pretty quickly recognize that's a face. When you turn it upside down, our brains really aren't programmed to instantly recognize upside down faces. It's not what we encounter often in our day-to-day life. And it takes us more time to recognize that these are faces. They look sort of like upside down horseshoes with little dots on them. But people with BDD more quickly recognize, oh, these are faces, probably because their brains have this ability to, sort of this over-focus on detail. And they're better, actually, at recognizing that these are upside down faces. I'm now going to turn to treatment. And I think one of the important things we've learned over the years is that most people with BDD get cosmetic treatment. About 3/4 get it, about 3/4 seek it, about 2/3 receive it. Dermatologic is most common, followed by surgery and other kinds of treatments as well, such as electrolysis. And as best we know, these treatments almost never help people with BDD, almost never. Most people, this is data we have on 890 treatments, most people after the treatment say they look the same, they obsess just as much, and they're often disappointed with that, because sometimes you spend a lot of money and you have pain sometimes with a surgical procedure. Some people actually get worse. A small proportion say, now the yellow shows the concern with the treated body part. Small proportions say, well, that looks a little bit better. I don't worry about it quite as much. But overall BDD, shown in red, almost never gets better, about 5% of cases. Because what tends to happen is even if the treated body part gets better, which isn't very common actually, people often, about half of cases, switch to something else. Or they're still obsessed about all the other things they hated about how they look. So cosmetic treatment is not a solution. And as best we know, it doesn't help. It can even make people worse. So we really recommend that it be avoided. So I've mentioned that we do have treatments that really, really work, which I'm just about to talk about. But first, one of the challenges is not everyone with BDD is so willing to do treatment. And I just think it's important if you are someone who has a family member with BDD or a friend with BDD, I would be very straightforward about it and just say, I think you may have this disorder. There's this disorder called BDD. A lot of people have it. It's really common. And, you might even say people with BDD see themselves differently than others do. Tendency to over-focus on details. And I think where everyone can agree is everyone can agree that the person is really suffering a lot and that this disorder is really affecting their life a lot. And perhaps that's where you can join together. It's hard to join together about what the person actually looks like because there are differing views, but it doesn't help to argue about that. I think just say other people see you differently than you do, but really we can all agree on this. And this is a reason to get treatment, is to find a way out of the suffering, to just try it. I think it's important, not to pursue cosmetic treatment, to be supportive, to understand that this is not vanity. This is a known disorder that causes suffering. And family members and friends can play such an important role It's unbelievable what I have seen over the years in terms of how supportive family members almost always are. And, you know, often supportive in terms of helping the person get the right treatment. And I think it's helpful, you know, it's probably not that helpful to try and talk the person out of their concern because it usually doesn't work. Tend not to get into the reassurance seeking if at all possible. That's just a ritual that gets reinforced when you provide the reassurance. Don't say, well, I see something, it's not that bad, because really, by definition, people with BDD really look fine. And I think it's better to focus on the suffering and the likelihood that treatment will work, the right treatment. So currently, there are 2 recommended first-line treatments for BDD that often work, and are usually well tolerated. One is the serotonin reuptake inhibitor medications. I'll have a few slides on those. This is key though. Often relatively high doses are needed. More like doses we use to treat obsessive-compulsive disorder. I do a lot of consultations for people who've had a lot of treatment and they feel like there's nothing left that I can try. I find that they have almost never had a good medication trial. They may have been on a lot of medicines, but the doses are almost always too low. Almost always. So you need higher doses typically, as long as they're tolerated, and the higher doses often are. You need higher doses typically than you'd use for depression or anxiety or many other disorders. And then cognitive behavioral therapy that's specifically designed to treat BDD, rather than, you know, really want cognitive behavioral therapy for OCD or for panicked attacks. You know, it really needs to be focused on BDD. So as I mentioned, these medications are often very effective. They're antidepressants that have anti-obsessional properties. We have 2 really good, what we call controlled studies, 4 open label trials, rigorously done, but all the patients knew they were getting the medicine. And we have response rates of 53 to 83%. Those are high response rates. That's just with 1 med trial. And often if that one doesn't work, there's another that may work. Here are the SRIs. I think the names may be a little different in the UK. The so-called generic names are the same, but the brand names are a little bit different here. But the generics, what is important, they're the same around the world. And here, just a brief, I won't go into detail, but just early on, we found that SRIs were helpful in our clinical practices for people with BDD. Open label trials with fluvoxamine, citalopram, escitalopram. Then these well-done controlled studies showing that the medication was more effective in this case than another antidepressant. So this is an SRI antidepressant, and then that fluoxetine was more effective than placebo. So these are kind of gold standard kind of trials, really suggesting that these medications often work. And here's the study of fluoxetine versus placebo. This is BDD severity, and you can see over 12 weeks how much better people got. And typically what gets better is the obsessive thoughts don't come into your head as often. And it's easier to focus your attention on something else. The compulsive behaviors, the urge isn't as strong. It's easier to just walk past the mirror and not get stuck in it. Depression and anxiety often improve. And it's often just easier to go out and be around people. And then people often recognize that they actually don't look abnormal in any way. So these medications can really help. They're currently the first-line recommended medication. I generally recommend that people stay on for at least a couple of years, enjoy your life, get back on track, start feeling well. I think for some people it's better to stay on over the longer term if you've had a fair number of, hospitalizations for BDD or maybe suicide attempts. It may be better to stay on indefinitely, but it's always a choice that the sufferer has, whether they want to stay on it or not. I think if you're going to stop it, it's best to plan ahead of time with your doctor and do a slow discontinuation at a time when there's not too much stress in your life. But trying a medication doesn't mean you have to be on it forever. It depends on the person, and you would have a lot of say in that. And I mentioned no studies have compared one dose to another, but it appears we often do need higher doses. And so you may or may not be familiar with some of these meds and the doses, but these are the average doses I use in my practice. This is as high as I would go, and again, these are much higher doses than we would typically use for depression or They're like doses like for OCD, and often well tolerated. Most people do fine. And to determine if an SRI is going to work, you need a total trial of about 12 to 14 weeks while getting up to a high dose. Now, if you need a lower dose, great. You don't have to keep going up. But if there's no response or only partial response after 12 to 14 weeks, you can consider increasing the dose. If you're tolerating it okay and you're not at the maximum dose, you can switch to a different SRI, or you can add another medicine in. And I mention this just because there are lots of options. We found that if you switch to another SRI if one doesn't work, decent response rate. There's some other medications that have been studied. This is another type of antidepressant. This is an anti-epileptic, anti-seizure medicine, actually, which we use a fair amount in psychiatry. These are just small studies. I just show you because these studies have been done, but we don't recommend them as first-line treatments. And then if an SRI doesn't work, but it works a little bit, you can add something else in. Buspirone, I think, is a good first choice. And then there are other medications that are available. And I just mention this because I think there are lots and lots of options, actually, for medication. Just a few myths and realities, and I hear I hear these things a fair amount. People feeling they should be able to get better on their own, and that somehow you're weak or defective as a person if you need medication. Nothing's further from the truth. You wouldn't say that if someone had really high blood pressure or diabetes. You'd probably take a medication in addition to making some lifestyle changes, perhaps. So BDD doesn't reflect weakness, and getting treatment doesn't. It's just a treatment for a disorder. Myth that they have the terrible side effects, but that's actually not true. Most people tolerate these medicines really well, and a good doctor will be able to adjust the dose if you're having trouble with side effects to help you tolerate it better. And in a recent study I did of 100 people who took one of these medicines, only 4 had to stop it because of side effects. So generally very well tolerated. Some people may think they're addictive, they're not. And some think they're bad for your health, but actually, as best we know, they're actually probably really good for your health. Not only by decreasing the stress and anxiety and depression, which aren't good for your health, but they seem to protect brain cells from damage or death. They seem to stimulate the production of new brain cells. And a recent study that just came out is quite amazing, showing that these medicines appear to decrease the risk of death from heart attacks and strokes. So by a lot, it was like by 50%. What if you tried an SRI and it didn't work? Well, first, was the dose high enough? I find almost never. So often needs to go up a bit, but talk with your doctor. Don't do it yourself. Did you take it for long enough? Generally, we recommend at least 3 to 4 months of giving it a try. Did you take it every day and not miss any doses? If you miss even 1 or 2 days a week, it may not work. If you had some side effects early on, did you work with your doctor to improve your tolerance and wait to see if they would pass, which they often do. And if you did all these things and it still didn't work, another one is definitely worth trying. They're different. Each one is different. We have 7 of them. Another one may work for you. Now, cognitive behavioral therapy has been shown as the other first-line treatment for BDD. It's a very practical, here and now kind of treatment that directly targets BDD symptoms and helps people with BDD learn to overcome their symptoms. And ultimately, you learn to become your own therapist. Your therapist is kind of like a coach. It's kind of like learning to play the violin. It's like learning to become a good athlete. You have to practice, and eventually you get really good at it. You need to practice them every day. That's really important. And I do recommend that your therapist use a treatment that directly targets BDD symptoms. And there are 2 manuals that have been published that have been shown in research studies to often improve BDD symptoms. This is Dr. Veal's treatment manual. This is one that I and my colleagues developed, and it's a step-by-step guide to therapists to use when treating BDD. Very helpful guides. So some of my patients will buy these books if they're on Amazon and give them to the therapist and say, would you please use one of these? Because it's challenging to treat BDD without using one of these. So I recommend them. And there have been a number of studies that have studied the effectiveness of CBT. This is a really nice study recently published that Dr. Veal did, and suggesting that, or indicating that CBT is often effective. So the components of, first we spend a lot of time with numerous initial sessions with the person with BDD, trying to understand their BDD. We call it a model for BDD, and how ordinary appearance concerns, which everybody has, passing thought, oh, I don't like how my face looks today, but how in BDD your mind is this filter that has these self-defeating interpretations. Oh, this must mean I look really ugly. And then there's the selective attention and over-focusing in the mirror, which probably changes how you see yourself. And then it leads to distressing feelings, and then self-defeating coping strategies like, you know, mirror checking and the rituals and the avoidance. And then those behaviors just feed back into the BDD thoughts, and it goes round and round and round. And the elements of CBT actually target these different pieces of this reverberating circuit and try to stop it and interrupt, you know, for example, help you get better control over the rituals. Now I'm going to tell you a bit about our treatment. I think Dr. Veal's is fairly similar. There are a lot of overlapping elements. You know, we really set the stage with what are your goals for treatment? What's important to you? What would you like? What progress would you like to make? We go in the treatment. We go over the model I just showed. We do something called cognitive restructuring, where we help people learn to identify their unrealistic negative thoughts and some of the thinking errors that people make. People with BDD tend to do a lot of mind reading, thinking they know what other people are thinking, usually assuming it's something bad. And we help people realize that really we don't. I mean, I'm a psychiatrist, I can't read people's minds, so it's just not helpful to do that. And so we have people learn ways to develop more accurate and helpful beliefs. We also help people with BDD gradually face their feared and avoided situations, but you can't push too hard or too fast. It's very gradual, and you learn skills to be able to do that and go out and be around people. And importantly, we help people get better control over those compulsive behaviors so you don't spend so much time on them and stop doing them ultimately. Cognitive behavioral therapy, there's a lot of writing and forms that are filled out, which are very helpful. We also do some work with mirrors, but we don't encourage people to stare in mirrors. We just have people non-judgmentally describe their body from head to toe in only about 5 minutes, non-judgmentally from head to toe. So you see your entire body, not just little things that you don't like. And we also work on these deeper level beliefs that many people with BDD have. I'm worthless, you know, I'm inadequate. We help people with BDD get motivated to do treatment. CBT is a doable treatment, but you do have to have some motivation to give it a good try. And then we prepare for the end of treatment. Our treatment also helps people get better control over the skin picking and hair plucking that some people with BDD do. We help people who think they want cosmetic treatment, which is not recommended. And we have some approaches for people with more severe depression. A few myths about CBT. I hear these a lot. Same as with the meds, I should be able to get better on my own. And that's not true. There are things you can do. You can work with your doctor, with your therapist. You can do the CBT homework, but you shouldn't expect yourself to get better on your own from BDD or feel badly if you can't. CBT is too scary. No. Talk with your therapist. If it's too scary, tell them. You work with them. You develop the treatment with them. And yes, you need to be challenged, but it shouldn't be too scary. It does take some courage, but the idea is for the exercises to be doable. A myth, I'm too busy, CBT will take too much time. I hear this a lot. But if you really start doing some simple math, and you think about the amount of your time that CBT will actually take, it's maybe 1% to 2% of your waking time. And some people are spending half of their waking time on BDD. So ultimately, CBT will save you a lot of time. And CBT will just mask my real problem. I hear that about the medication sometimes too. No, BDD is the real problem, and these are the recommended treatments, and they can really help you overcome it. So what if you tried CBT and it didn't work? Well, was your therapist, do they have some CBT training? The therapist needs some training in CBT. And did you really get it? I find most people who see me didn't really get real CBT. Did they try one of the manualized treatments that I mentioned earlier? Did you participate by doing homework and doing the assignments? It does take practice. Were you too depressed at the time to fully participate? Sometimes it's really helpful to get a medication first that alleviates the depression, and then, at least to some degree, and then you can more fully participate in the CBT, or our treatment manual also addresses more severe depressive symptoms. Did you have enough sessions or frequent enough sessions? I think once a month is probably not enough. We recommend weekly. And we recommend about 6 months of weekly treatment. So if you only had it for 2 weeks or 2 months, that's probably not enough. And even if you had a pretty good trial, see, it's worth trying again with a different therapist, or perhaps with a different treatment manual. If one didn't help you, your therapist could use the other one. And also the medication and CBT work very well together. We don't know which treatment is better. I think they're both wonderful options. Do recommend avoiding cosmetic treatment. You do need to address any co-occurring disorders that may exist. I think it's very important to seek and accept social support if people are reaching out, offering to give you support, offering to go to a treatment session with you. I encourage anyone suffering from BDD to accept that. I do think it's important to practice some self-care. Now that can be hard when you're suffering with BDD, but just some basic things, if it's at all possible. If your illness isn't that severe, to get some exercise and eat well. And some people find meditation or mindfulness or a spiritual practice really helpful, or trying to do at least something that's meaningful to you during the day. I think these kind of self-care activities, if you can do them, are really actually quite important. Not sufficient to overcome BDD, but in addition to the treatments I've been talking about, can be really helpful. And for the carers, I recommend that you do these things for yourself, and sometimes it's very helpful to get some support for yourself. So don't let unfounded fears about treatment get in the way of alleviating your suffering and improving your life. Please give the recommended treatments a try. Just do it. Just do it. Take that leap if you're anxious about it. I think you have nothing to lose and everything to gain. And also, knowledge is power. I find, especially with the medications, people don't want them. It's often based on misconceptions and fear, or something you read online. Beware of what you read online. Some of it's excellent and some of it's really not helpful and actually not true. Maybe it was true for that one person, but not for 1,000 other people. I often suggest to patients, why not just try one of these medications, the SRI medications? Give it a good try, and then you will have some knowledge. You will know, how does this affect me? Is it helping me? And then you can make a decision. Do I want to stay on this or not? But if you never even try it, you won't know. And you will continue to feel badly, probably. So, although again, CBT may be helpful as well, but just knowledge is power. Give it a try. Really nothing to lose and potentially so much to gain. So I think my final message is to maintain hope, and just to remind you, each moment is new. Each morning is new. Your life to this point, of course, matters. It's important, but we can make a decision to do something differently now. You may not have wanted to try one of these treatments in the past, but you can decide right now that you'd like to try. And recognize, just even if you think you don't have BDD, I think if others are telling you that you do, take it on faith. Try the treatment. Again, you have nothing to lose and absolutely everything to gain, everything. And most BDD sufferers, with the treatments I've described, will get better. Sometimes partially better, which is a big relief and can really make your life better, and sometimes completely better, completely better. So I just encourage all of you who know someone with BDD or who have BDD to keep up your hope, give these treatments a try, and I have no doubt that in the future we will have more treatments for BDD, and probably better treatments, and there'll be even more options for you to choose for. So I really think that the future is very bright for everyone who has this disorder. And thank you so much for being here and for caring so much about BDD. Thank you.